Hello everyone, this is going to be the Module 2 Neurologic Part 1 PowerPoints for your Week 3. I will do another PowerPoint recording for Week 4. So the Module 2 reading, these are the required readings for this section. We have Chapter 35, 36, and 37 from your FA Davis book, and then we will have these recommended readings from your ATI book. The major concepts we're going to be going over, the assessment of neurological function, brain disorders, and spinal cord disorders. So the content outline, this is going to be what we're going to go by. We're going to talk about the introduction to stroke. We're going to talk about increased cranial pressure. We're going to talk about the brain disorders. And then on the next PowerPoint, we're going to be talking about the spinal cord disorders. All right, so we're gonna just start off with a little bit of anatomy, just a little basic stuff. Central nervous system, this is gonna be consisting of the brain and the spinal cord. And then the peripheral nervous system is the PNS, which is 12 pairs of cranial nerves, 31 pairs of spinal nerves, and it also includes the autonomic nervous system. This is an image from your book right here. All right, so we do want to know and memorize this slide. So this kind of breaks down the autonomic nervous system. So you have the parasympathetic and the sympathetic. You guys need to know this, so please take some time to really know these symptoms. Like the fight or flight for the sympathetic, it talks about how the eyes, the pupils dilate, increase or inhibits saliva production, it dilates the bronchi, it increases the heart rate because you have that fight or flight, stimulates glucose release, and all these things, right? And also the parasympathetic. All right, so for the neurological assessment, one thing you guys need to know about this is the main kind of like bread and butter for your assessment here is knowing the level of consciousness. This is the best indicator of neurological deterioration when you are doing assessments, is a change in level of consciousness, okay? But the first step that we do want to do is go ahead and complete that history, get a full medical history from the patient, find out exactly what medications they're on, what medical histories they have, what allergies, and even like the chief complaint when they come in. And then again, you want to focus on that level of consciousness. One of the main tools we use for that is called the Glasgow Coma Scale, the GCS. Be familiar with that. One of our general rules in emergency or critical care is if GCS is less than 8, you're going to intubate. So, and then here are some other tools like the mini mental, other things that you're going to be assessing, the cranial nerves, motor, sensory. One thing I do want to talk about in this section right here is when you would want to alert the provider, right? So a lot of nurses, especially when they just come out of school, they don't know, hey, they don't want to sound bad, so they don't want to call the providers. One thing that you do want to alert the provider on, regardless of the time, if you're a night shifter, you work 3 a.m., if there's a change in level of consciousness, or if they have abnormal pupils, they start having slurred speech, or a sudden onset of like headache, or like, this is the worst headache of my life, you would want to let the provider know, okay? All right, everyone, one of the main things that we do use for a neurological exam is the diagnostic testing. So the imaging studies will include the CT scan, MRI, MRA, and cerebral angiography. The CT scan, for if you're concerned about stroke, that is going to be your go-to. We'll talk about that in a little bit. And the cerebral angiogram, one thing to note about this is that you do go through an artery. So it is an exam where they go through an artery. So after the exam, when you're taking care of your patient, one thing you want to kind of monitor for is bleeding. If they do have bleeding, number one, you're going to apply pressure. You're going to ask for some assistance, some help, because you want to make sure that the bleeding is controlled. And you're also going to notify the provider. So that's really important, okay? For functional electrical studies, you'll have the EEG and PET scan. And then you have the invasive procedures. We consider lumbar punctures as invasive because you're sticking a big needle, a really big needle, in their spine. Not you personally, but the providers will do that. But you may be asked to assist. So setting it up would be a thing that nurses would do to kind of help with that. And also another invasive procedure is the biopsy. All right, so the stroke, we're going to talk about stroke a little bit, overview and urgency with strokes. Strokes, as you all may already know, super urgent. Is an emergent situation if they are actively having a stroke. Stroke is a medical emergency. So basically there's a disruption in the cerebral blood flow, and just tell yourself time equals brain. So the sooner we identify what it is, the sooner we start treating them, equals like just really perfusion into that brain, and we can prevent brain damage. Okay, and the rapid assessment is essential for a nurse. So when you notice a change in level of consciousness, it's important to really just notify the provider. Okay. All right. So initial nursing priorities. Um, know the signs and symptoms of stroke. You do have to assess them. So you as a nurse, it's important for you guys to know those things. It does take precedence over any other medical issue. So if you think they're having a stroke, even if their blood pressure is high, they have diabetes and their blood sugar is high, we are going to be taking care of that brain, because all those other body parts is not going to function without a brain. Okay, so it's important that we do prioritize stroke, or if you're concerned about stroke. Neurological assessments, this is something that you will be doing first. Establish a baseline. Again, that level of consciousness is super reliable in kind of identifying the first steps, right, of what you need to do as a nurse. If they have issues with their speech, any motor strength, if they're weaker on their left side, all of a sudden, that's an issue, right? And then you see that facial droop, or any asymmetry in their face, you're going to be really concerned, okay, that it might be a stroke. The diagnostic testing, again, we're going to talk about it. The main thing is you are going to do a CT scan, okay? And the CT scan that we do is without contrast. So the reason for that is if they have a bleed and we put in contrast, guess what? Now they have a bleed and contrast in their brain, right? So we want to make sure that we do it without contrast, and it does check if there's a bleed or not, okay? Additional things that we're going to be looking at, CBC, coagulation studies, and also an ECG. All right, for swallowing and medications. So one thing that you guys need to really prioritize is, hey, can they swallow, right? That's a big issue. So if they are having stroke-like symptoms, you want to make sure that we do not give them any oral medications, anything oral, until they pass the evaluation, the swallow evaluation. Sometimes the provider get super excited, and they're like, I'm going to treat this, I need to do all these things, and they put in their orders, and they put in orders for PO medications. As a nurse, you're the last line of defense, so you want to make sure that you don't give those pills, right? So you want to contact them and say, hey doc, you ordered PO meds, this patient did not have a swallow study yet, can we change it to IV? That's something that you can do as a nurse, right? So one thing, the main reason for that is we don't want them to aspirate. So there's a big aspiration risk when they do have stroke-like symptoms, and as a nurse, you want to protect their airway. All right, guys, we're going to be talking about the increased intracranial pressure now, our ICP. There's two components that we want to take a look at. Number one is brain control and vital signs. And number two, we're going to look at the increased intracranial pressure and what we're going to do about it, okay? When you do have ICP, it is very important for you guys to know that it is a medical emergency. So here we go. So basic anatomy, we're going to talk about the skull. The skull has three things in it, right? We have the brain tissue, cerebrospinal fluid, or CSF, and then we have the blood. So with a skull, it can't expand. Is a bone, it doesn't expand. So what happens is if there's an issue, if there's a disruption of some sort, the pressure can increase, right? If the body is not able to compensate and to regulate all that, you'll start seeing that increased intracranial pressure. All right, so these are the values. I would highly recommend you memorize them, but with the values, just know that above 20 is going to be an increased pressure. It is going to be abnormal, and we need to treatment. Okay, we need to treat it. Some causes for ICP: you might have a lesion or a mass, a tumor or swelling. Again, they're fighting for that space inside the skull, so you're going to be anticipating some sort of increased pressure if the body can't regulate it. Bleeding in the brain, right? We just talked about stroke. So if they have trauma, if they have a hemorrhagic stroke, that's something that's going to be fighting for more space in the brain, and again, it might increase that intracranial pressure. If they have a blocked CSF drainage, and also meningitis, right? Like infection, different kind of infections can cause this, okay? So this is straight from your book. So this is basically kind of like a guideline on what we need to do. It's a safety alert, right? So what you want to do if someone is suspected or if they do have an increased intracranial pressure, you want to make sure that you're sitting them up about 30 to 45 degrees, just to make sure we're helping the venous part of their brain like drain it out so it doesn't just kind of like swell up, okay? All right, signs and symptoms. So early signs, you'll have that decreased level of consciousness. We will probably go back to that over and over and over during this lecture, just because it's so important for you guys to know that. Early signs, you'll see them being restless a little bit. They might start having headache. They might even like have some vomiting. But late signs that we'll start seeing, they might have a seizure, right? Super serious. We'll go over that later. If you guys check their eyes when you're doing part of your neuro exam, you're checking their pupils, if it's reactive, if it's equal, if it's unilateral, meaning one side is dilated, that's an issue. You're letting the doctor know, okay? And then obviously we're going to be looking at vital signs. All right, so the brainstem, again, we're talking about this, the brainstem and the brain, it controls the heart rate, the blood pressure, and the breathing. Something with increased intracranial pressure, something called Cushing's triad is going to be something that we might see. This is not good. Okay, so you'll see that they have a high blood pressure that's wide, meaning it's like 190 over 70. Right? It's such a wide gap in their pressure. You might see that, irregular respirations, and again, their heart rate will go down. You'll see a decrease in heart rate, and this is called the Cushing's triad. You might see this in someone who has that increased intracranial pressure. So what I would say is definitely know that the brain and the brainstem, controls that, the heart rate, the blood pressure, and the breathing. And please know this slide, okay? All right. So brain disorders, we are going to go to seizures now. This is in chapter 36 of your book, page 847. All right? All right, so a seizure basically is a sudden uncontrolled burst of abnormal electrical activity in the brain. That is a pretty definition for what it is, but it doesn't look pretty when it actually starts manifesting, right? So it may cause behavioral changes, motor activity, or loss of consciousness, again with the level of consciousness, right? So it is divided. Cryptogenic seizures, the cause is unknown. Epilepsy is a chronic form of it, 2 or more unprovoked seizures occurring more than 24 hours apart. And then the possible causes of it, some of the causes, right? They could be overstimulated, or they can have some meningitis. They might have a tumor, or again, the increased intracranial pressure. So types and classifications, so they're classified by 2 ways, okay? Where the seizure starts in the brain and whether awareness is impaired. 2 different categories that we're going to take a look at, focal or partial seizures, and then generalized seizures, which really activates both sides of the brain. And the classifications help you with your care and how to proceed about how to treat it, okay? All right, so the International League Against Epilepsy, or ILAE, created a classification system. So this is straight from your book. So go ahead and review this. All right, so your priorities as a nurse, whenever someone has a seizure, you want to make sure that you lay them side laying for that recovery position. You have oxygen ready to go. You're going to assess the airway, the O2 saturation. You're going to administer some sort of benzo to help it. Normally what we give in the emergency room is something called Ativan. So I don't know if you're familiar with that, but we do give benzos to help that. It kind of increases the threshold for the seizures. We'll call a rapid response if they're actively seizing. We'll check for medication orders because the provider will be notified, right? And then we're going to check if they have IV access. There's times where it's an emergent situation and it's just going really bad. So sometimes you can't get that IV access. You might be able to get an IO or intraosseous where they will drill into the bone, and then you can get the medications through that, okay? And then obviously safety measures. All right, so status epilepticus. So this is a seizure that's lasting longer than 5 minutes. So that's not good for the brain, right? Or repeated seizures without recovery. So status epilepticus, it is an emergency, but there are some ways that we're going to be treating it, okay? One thing that you do want to know about that is it we were going to treat it with medication. Diazepam is the go-to medication. Phenytoin is an anticonvulsant. Carbamazepine, also another one. And then what I do want to talk about with carbamazepine in particular is because there's a bunch of like black box warning that goes with these kind of drugs, right? With these medications. So one of the things that it can cause is called Stevens-Johnson syndrome. So this is just a serious allergic reaction, like a skin reaction. You're going to want to stop the medication, right? But sometimes the skin can get really bad where it starts to blister and even peel. Often it could be like, starts off feeling, they feel like they have a flu, or they just don't feel good about it, but it can affect their body, okay? Having this, when they start having this, it is also a medical emergency, and we're gonna stop the medication, all right? Another thing is, the next part is the toxic epidermal necrolysis, okay? Or TEN. So this is, we just talked about how Stevens-Johnson's is a medical emergency. This is a more severe form of that. The skin will literally die, it'll slough off, and this is going to be an issue. So this is the medical emergency. We're going to treat it like it's a severe burn. They're going to go to ICU. They're going to go to a burn unit, okay? So the medication can cause that, right? Aplastic anemia, basically the bone marrow stops making red blood cells, or the blood cells in general, red, white, and even platelets. You can see them being more fatigued. They'll have infections, increased infection because their white blood cells decrease. They'll have increased bleeding because their platelets, right? It can be really fatal if we kind of miss it, right? So it's important for us to assess our patients. And then also it can cause agranulosis, which is, again, with the destruction of the blood cells, or they don't make it as much, they will have severely low neutrophils, so they're going to be prone for infection, okay? Hyponatremia, their sodium levels are low. That could, they can cause them to continue to start having seizures more and again, and then they may have suicidal thoughts or bleeding. Those are just things that can cause are side effects from the carbamazepine. All right, so post-ictal. So this is important for you guys to know, because post-ictal can last from minutes to like a while, right? So post-ictal period is basically the brain, it just had all these things sparking, and now the brain is kind of like trying to, it's like when you reboot and you're rebooting, and it's just like the rebooting now, right? So this is the area where they're kind of like recovering. One thing that you need to know during this time, you're obviously going to be getting vital signs, but you're going to place that patient in that side laying for that recovery position. Sometimes patients who have seizures, they can vomit, right? We don't want them to aspirate. We put them in that side laying position. We're going to assess them on a regular basis. Hey, are you all right? Are you awake? We're gonna assess their level of consciousness. We're gonna reassure them when they're awake. Hey, you're safe. I'm here for you. We're gonna take care of you. You want to be able to give them that integrity. Sometimes when they have seizures, they just don't have control, right? So sometimes they'll pee their pants. Sometimes they'll poop. There's a lot of different kind of manifestations when they do have seizures. So just make sure that you're giving them that level of integrity. Education. Again, this is something that you're going to teach them, but also teach their family members, right? We're going to teach the family members, like, hey, we're going to protect the head. We're going to, if they're having a seizure or somewhere they could hit their head in a hard place, you're going to, put soft things, maybe a pillow or like something close to their head just so they don't get that injury. We're going to turn them again to the side. That's super important. Any sharp objects around the area, we're going to remove that. If they have restrictive clothing, we're going to loosen those things, right? And then also what we want to do is have them note the time and the onset and the duration of the seizure, because we want to track it. Are the medications working? Is it worse than last time? Is it getting, is it less? Like that's some of the things that the providers want to know, and we want to know it too, right? So, and then we're going to protect them from injury. That's one of our main priority with seizures. All right, meningitis. So meningitis is just an overview slide of it. Meningitis is inflammation, anything itis, right? It's an inflammation. So this is the inflammation of the meninges around the brain and the spinal cord. This can be caused by a bunch of different things, but mainly bacterial infection, viral infection, or even fungal or aseptic causes, okay? Or idiopathic means we don't know what caused it, but usually these are the top three that kind of cause it, okay? So acute bacterial meningitis is a medical emergency. So you guys need to know that they're going to be isolated because it's highly contagious, right? And then risk for increased intracranial pressure. And again, with that, you have the increase in risk for seizures as well. All right, so clinical manifestations. So with adults, common symptoms, you'll see fever, severe headache, photophobia, like, just kidding. They're not scared of the light, but they are sensitive to the light, okay? That's what it means. Then you have the nausea and vomiting, and then the altered level of consciousness. Again, we're going back to that. So the if it's the meningeal sign, these are 3 signs that they might have meningitis, okay? So the first one is nuchal rigidity. So what that is their neck is stiff, right? They're like, oh man, my neck, it doesn't feel good. It's a little stiff. We're not going to automatically be like, oh, it might be meningitis, right? But there's other signs, but that is one of the signs, okay? So they have that rigidity for it. So the Brudzinski sign, that's an involuntary flexion of the neck or of the hip to passive flexion with the neck. So they kind of like go this, and the hip kind of goes back up too as well. That's what it looks like. There's a picture in your book, so please review that. And then the last one is the Kernig signs. And this one is the pain in the back of the leg or the hamstring, and they have resistance to movement when the leg is flexed at the hip. So there's a resistance there. So you could even like try, try to pick it up, and then there's a big resistance, and then straightening at the knee, right? So there's a big resistance when you're doing that for that exam, okay? All right. So the next one, diagnosis. How are we going to diagnose this, right? So the diagnostic testing that we do mainly specifically for this one is we'll do a lumbar puncture. The provider will do the lumbar puncture, and again, we will assist, right? So the needle is this big, they'll put it in the back. There's 2 different positions. You guys can review that in your book. But usually if they can't set up, we will put them on their side. But ideally, if you can, most of the ones that I've seen, they're sitting up, right? So the provider will stick this big needle in their back, and then the needle or the fluid, the cerebrospinal fluid, should come out clear. If it comes out cloudy, we're a little concerned, right? So we'll send that off to lab. If it has a gram stain, they'll do a gram stain on it, and they'll kind of identify what's going on. If there's white blood cells, that's an indication of infection. We're concerned about that too. Another thing we're going to look at is we're going to do a CT of the brain. So they might even do the CT prior to the lumbar puncture. The lumbar puncture is considered invasive. And a CT scan, we just do the CT scan right away first, and then we'll do the lumbar puncture afterwards, okay? Again, with a risk of increased intracranial pressure, and there's a seizure risk that goes with that, and then we'll also do a CBC with the lab, okay? To see if their white counts are elevated. All right, so nursing priorities and safety. Priorities as a nurse for someone who has meningitis, we're gonna do frequent neuro checks. Okay, we're gonna monitor their vital signs very closely. We're gonna watch signs of increased intracranial pressure. Again, it's considered an emergency, and then we're gonna make sure that they complete their antibiotics. That's an education that we're gonna teach them. Hey, you need to complete your antibiotics, right? Because that's what's gonna treat it. Another safety consideration, we're gonna look out for the seizures again. With everything going on, you want to make sure that the environment is quiet, so they have that low stimulus, and again, that their head of the bed is elevated. The reason for that, again, is we want to make sure that if they do have the ICP, that we're facilitating the drainage of that through the venous system, okay? All right, so encephalitis. So encephalitis, again, is that swelling or the inflammation, right, of the brain tissue, usually caused by infection or some sort of autoimmune disease. So these are the signs that you guys should know. This is also considered a neurological emergency. A lot of these are emergencies, right? So we will act fast. So again, it can cause increased, ICP, and then we have the seizures that goes along with it. The signs and symptoms for these ones are very similar to meningitis, right? One thing about this one though, you see photophobia and then phonophobia. Phonophobia is they're sensitive to hearing, right? So this is specific to this one, so you might want to take a note of that. But yeah, so they are sensitive to sound, okay? All right. So again, with the diagnostics part, we're going to do CSF studies. So they'll do the lumbar puncture again if it's safe. They'll do a CT or MRI of the brain and EEG if it's indicated. Priorities, we'll do your neuro assessment is so important. So it's important for you to get that down, okay? We're monitoring the vitals on a regular basis. We're going to look for those signs. We're going to complete antibiotics again. And again, with the safety considerations, it's very similar, it overlaps, okay? We're looking out for seizures. One thing to note about this is that they may recover, the recovery may take weeks or even months, okay? The head of the bed is going to be elevated, and then for this, we do want to give them stool softeners, and the reason for that is we don't want them to strain if they do go to the bathroom, because if they strain, it increases the pressure again, okay? All right, Huntington disease. So this slide has all the information you need to know about Huntington disease, okay? So it is progressive, so that's something that you need to know. It is neurodegenerative or degenerative disorder. It is autosomal dominant condition that affects the basal ganglia. And then also it usually is diagnosed when they're adults, right? When patients are adults, and then the disease is progressive and is fatal over time, okay? The clinical manifestation for this, they have involuntary movements or chorea and athetosis, right? So they have those involuntary movements. They have a progressive motor decline. They might have those impairments, like dementia-like changes. They obviously, when they have these kind of diseases, they're prone to being depressed, irritable, or even suicidal. And then dysphagia, it leads to weight loss because they can't swallow, right? So the one thing that we do want to take note about this is they might not be able to swallow, okay? So just like the stroke patients, we want to, this is like a prolonged disease. So if you can't swallow for a long time, you want to make sure that, or if they're having problems with swallowing, we want to make sure that their nutrition is on point. Okay, what does that look like? We're going to give them some sort of high-calorie, nutrient-dense snacks in between meals because they're going to have weight loss. So we might give them supplements, some protein. We're going to give them thickened liquids because it's harder for them to swallow. So regular like water, they might aspirate that, right? As a priority for a nurse, because they're losing all those motor movements, you're gonna, keep an eye out. They might be a fall risk, right? So fall precautions. We're gonna monitor their swallowing. Again, we're gonna elevate the head. So when they eat, so they don't aspirate, they have a less chance of aspirating. And then we're gonna consult with speech therapy. And then we're just gonna support them and then involve the family in the planning, because whenever there's diseases like this, it does involve the family as well, because they do have to live with that as well, right? All right, so Parkinson's overview and pathophys. So basically, Parkinson's is a progressive neurodegenerative disorder as well of the CNS. It's caused by loss of dopamine producing cells. So this results in imbalance between dopamine and acetylcholine, and it leads to a lot of impaired control of voluntary movement, okay? Parkinson's, a lot of things that you'll see, I know they're one of the notable signs, not everybody does it, but like they'll do some pin rolling with their movements. They write small. I write small, but I don't have Parkinson's, but they might be writing small when they're writing. So the key factors that we need to take a look at that can cause it, sometimes is idiopathic. They have environmental toxins, some sort of brain injury or tumors, or there's a genetic components with Parkinson's as well, okay? Clinical manifestations, so there's 4 distinctive things that we'll see. They'll, at rest, when they're just chilling, watching Netflix, you'll see tremors, right? Not when they're just trying to grab something, but just at rest, you'll see that tremor. Their muscles are a little bit more rigid with their movements. You'll see bradykinesia, which is a slow movement, right? So they'll have the slower movement when they're grabbing something, or they might have loss of movement altogether, right? And then you have the postural instability. This talks about the gait and the balance, right? They might be a big risk for falls, so that's something to look out for. Another like other manifestations that you'll see, when they're walking, they'll have that shuffling gait, mask-like face expression. They might be drooling. They might have issue with swallowing. With Parkinson's, my girlfriend's grandpa had Parkinson's, and towards the end, he actually ended up passing because he aspirated when he was eating. So dysphagia is a real thing towards the late stages of this. And then they'll have that cognitive and mood changes as well, okay? All right, so nutrition, swallowing, and priority concerns. All right, so nutrition and GI management, what we want to make sure we give them is this high fiber diet, right? So this will help with them with their constipation. They are prone to constipation with Parkinson's. We want to give them a balanced diet overall, and then they might have a weight loss due to the increased energy expenditure, okay? That goes along with Parkinson's. We're talking about whenever they eat, we're gonna set them up again. You're gonna see a kind of like a pattern with a lot of this, like because we're looking out for the same things, right? So if we're concerned about aspirations, when they're eating, we're gonna sit them up. You know what I mean? So again with this, so we're gonna sit them up, and we're gonna monitor them while they're eating for if they're coughing or they're choking on things, a possible dysphagia, and an aspiration risk, and this. When they aspirate, that can lead to pneumonia and they can pass, right? So we don't want that. Mobility priorities. So if they're having problems with their mobility, you start seeing that, we're really concerned about them being a fall risk. They may need to use assistive devices, and then we will get physical therapy involved, okay? All right, so the nurse management and interpersonal care. We talked about getting physical therapy involved already, but occupational therapy will also help them with their ADLs, right? Putting on their clothes. You know, even just moving around, just brushing their teeth, brushing their hair. We'll get occupational therapy with that, and then speech therapy for the swallowing and communication, okay? We are going to be assessing their gait. That's super important, just to make sure that they're not a fall risk, right? We're going to monitor their bowel and bladder functions, and again, we're going to elevate their head. And then education, everything that we just talked about, everything that I've just talked to you about, we're going to talk to their family about it and to them about it in simpler terms, okay? And please note that this is progressive. This is a progressive disease, and you know, the medications that we do give is to kind of help with the symptoms, but it is a progressive disease, okay? All right, Alzheimer's. Alzheimer's and dementia, so this is just the overview page for that. And I do want to touch on their decision-making capacity as well, okay? So dementia is progressive decline in cognitive function, right? So it's cognitive, where Parkinson's is more motor. This is more cognitive, right? So Alzheimer's is most common cause of dementia. They have a progressive loss of memory, thinking, judgment, and behavior, and as well, the diagnosis is clinical. They can only confirm it by an autopsy, which we're not doing that when they're alive, right? So it is clinically diagnosed by the providers. Decision-making capacity. I do want to touch on this just because it's also important for you guys to know that when they have Alzheimer's or when they have dementia, there's a lot of times where they cannot make decisions for themselves, right? So you need to ask, or kind of like ask yourself these things, right? Can they explain the purpose of medications? Like, why are they taking it, right? Can they explain the consequences of treatment choices? Are they oriented enough to understand what you are talking about, right? And then also, I do want to note that the capacity mainly deals with also task-specific things. It's not just like, oh, all or nothing, right? So you can note certain parts, what they can and cannot do, okay? Oh, I do want to say that if they can't make decisions for themselves, that's when you would have their POA or you know, like their guardian or whoever, the family member who's in charge of that to make those decisions, you know, for signatures, stuff like that, okay? All right, so clinical manifestations. So the early part, they'll start having short-term memory loss, right? I forgot my keys, right? We don't all have it, right? But you know, they'll start doing it more often. I forgot this, I forgot that, right? They'll start forgetting familiar words or like locations, okay? When they start talking, they start having difficulty just understanding when they're having conversations with people, or they start misplacing everything, okay? As it progresses, we'll start seeing agnosia, which is the difficulty in actually recognizing objects and people. When you guys see Alzheimer's in movies, this is pretty much one of the things the main thing that they kind of pinpoint on is agnosia, and that's just them, they can't recognize people, right? They'll be flat in their affect, their behavior, their personality kind of changes. It can change, right? Not necessarily all the time. They might have that increased confusion or disorientation, and this is kind of like what you see in the movies, right? And then the main thing is with Alzheimer's, they don't have that shuffling gait because again, this is cognitive, not motor, right? So it's important to know that. I just wrote this in here just to differentiate it from Parkinson's. All right, so as far as medications, so with medications and kind of the progressions of this disease, I just want to let you guys know the main thing is that we want to slow the progression. It's not a cure, okay? So we just want to slow it. They are going to be progressing in this disease, but we want to slow it as much as we can. It will not stop the disease from progressing, unfortunately. I wish it did, but it doesn't, right? So it might help with their physical and emotional responses, and again, it's really to increase their quality of life, right? The medications that I want to go over right now, memantine, so Namenda. So this reduces the symptoms of moderate to severe Alzheimer's. And then cholinesterase inhibitors. I listed some of the drugs here, but this will help with like the memory and the cognition. Aricept, I'm very familiar with. Exelon, I know. I've not really given a lot of Razidine, but for the most part, like these cholinesterates, they do help with the memory and the cognition, okay? All right, so this is the last slide. I'll go ahead and upload the other slide as well for week 4. So that's the second part. But please review. Make sure you guys are studying your books. And yeah, I'll see you next time.